Good evening. I'd like to thank organizing committee, Bangladesh Oncology Club, and Radiation Knowledge for giving me this opportunity. And myself, Mr. Samuil Alim, working as an experimental officer, Institute of Nuclear Medical Physics, Bangladesh Atomic Energy Commission. And today, my topics is setup, immobilization, and simulation in cervical carcinoma.
A quality radiotherapy program starts with a quality setups and precise immobilization. So if it comes to the introduction, we can see the cervical cancer is the second commonest female malignancy worldwide. The cervix is cylinder-shaped neck of the tissue that connects the vagina and uterus, and it's anteriorly related to the bladder and posterior to the rectum, and its position varies regards to the bladder or rectal filling, which I will discuss in my next slides. Now comes what is the immobilization. Immobilization means to immobilize the patient in comfortable yet reproducible manner with the help of immobilization and positioning devices. And immobilization devices are used to make proper patient positioning during the course of radiotherapy treatment. Why immobilization is required? To limit the patient motion, to reduce the setup errors, to reduce the time taken for the daily patient setups, to make the patient feel more secure and less apprehensive, to stabilize the relationship between the external skin marks and the internal structure, to reduce the irradiation to normal surrounding tissues. And this is a funny picture of radiotherapy immobilization. And we should not make, and though it is a funny picture, it's carries lots of words, like we should not make immobilization device that way, which is hurting the patient or which is not comfortable for the patient, and which we cannot reproduce every day. The immobilization device which should be like reproducible and which is more comfortable for the patient. Then we'll get the much benefit during treatment. And if we divide the patient setup tools, and we can categorize in two types, like one is positioning devices and another one is the immobilization devices. Positioning devices is used for the positioning the patient, and immobilization device is used for the immobilize for the patient. Like in positioning device, ankle rest, knee rest, belly bulb, etc. And for immobilization devices like backlock and thermoplastic mask or pelvic mask. So for pelvic immobilization, basically we are using like ankle rest, knee rest, and sometimes backlocks or pelvic masks we are using. And here I put the three pictures. First one is the knee rest and ankle rest. Second one is the backlock, and third one is the thermoplastic mask or pelvic mask. And we can use belly board also for cervical cancer. And there are some advantages to using belly board, like it's allowed to intestinal tract to push out from the treatment field. And the case of hysterectomy patient, a small bowel falls into the pelvic area, and belly board helps is of help in such patient. And some uncertainty also there. It is very difficult to patient set up in the prone position, and reproducible patient reproducible also a very much problem for the RTTs, because in prone position patient is not feeling comfortable. So this is the disadvantage of belly board. And if we see a comfortable radiotherapy system, it's a very complex process, and which is starts with the patient evaluation and 3T data equation. And radiotherapy success is depend on the, if I categorize the first, it's depend on the patient evaluation and data acquisition. And if I can evaluate in proper way, and if I can take good data from CT scan or CT simulation, during CT simulation, then oncologist can identify the tumor or he can control the tumor properly. And after that, structure segmentation, then treatment optimization. Then it will go to the planning system, then plan verification. And after that, position patient will go to the treatment area. Then we will verify the patient position. Then we'll localize the target, and after that, we'll deliver the treatment. And this is the process of radiotherapy, conformal radiotherapy system. And before simulation, one thing is very much important, which is patient counseling. And especially in our South Asian countries, this habit is not there. Many centers it is there, still it is developing in many centers. And it is this patient counseling is very much important because cancer patient become anxious during simulation, what they are going to do, what will happen to me, like many questions comes in their mind. So before simulation, we should discuss with the patient, like what we are going to do, what we will do, is it harmful for the patient, or uh, patient should not afraid, like this. So if we counseling the patient before simulation, uh, it will give patient mentally support also. So in simulation, we can position patient in better way. So let's come to the bladder and rectum filling preparation during simulation. Uh, Rectum and bladder filling preparation is very much important for cervical cancer uh, because um, due to the filling of the bladder and rectum, cervix is moving. So what is the preparation? First, empty the bladder and the bowels and drink half-liter water within 10 to 15 minutes. Then CT simulation is performed after 30 minutes. And this is the protocol in our center, and it can vary center to center also. And this is an example for the proper bladder filling. And this is the example for insufficient bladder filling. If we fill the bladder like this way, like insufficient bladder filling, then in during treatment, patient might get overdose in the bladder area. So it should not be like this. We should fill the bladder in proper way. And this is the over bladder filling, which is unwanted. We don't want like this, because if we fill the bladder more and more, which is push the uh, cervix or ovary, and we might not get the full dose to our target area. And this is the appropriate rectal distension. And during simulation, the rectum should be like this. And this is the abnormal rectal distension and rectosigmoid flutus. And it's very important, like if we do the simulation in this way, like abnormal rectosigmoid flutus is there, then uh, during treatment, this might not be there because of uh, the patient if digest properly. So we should avoid like this condition. And if we do the simulation, we do the plan in this condition, we might irradiate the normal structure rather than the target area. And what should be the ideal bladder and rectum preparation? The patient is asked to void the urine and stool before the simulation as well as the daily treatment. After drinking water, the time is noted and maintained properly for every session. Patient is asked to avoid high amount of vegetable. Patient is asked to eat those food which digest easily. And sometimes for purgative advice medication which improve the constipation, and we can use the rectal enema if bowels are not clear. And now comes to the important point, which is patient positioning. Uh, Irradiate the patient movement is possible, but be reduced within the um, acceptable tolerance. Immobilization device helps in reduce the lower extremity movement. Patient is positioned as straight as possible with the help of the wall mount laser. And patient position should be as much comfortable as possible. Marking over the immobilization device as well as the over patient body is done carefully so that it will help us in rating the position while throughout the course of the treatment. And what the patient positioning device we are using, like in first picture I can see we are using the backlog backlog for cervical cancer in patient is lie down in supine position, and second one is the with pelvic mask or thermoplastic mask, and third one is the ankle rest. We position the patient, but before positioning patient we should align properly the patient. And where we should place the RTP markers. In some center, in my experience, I saw they are putting the RTP markers over the backlog, but it should not be, because inside if patient moves also, or if inside patient rotate also, we cannot minimize the rotation. And always the RTP marker or patient marker should be inside the over the patient body only. Then we can minimize the patient rotation also, and we should mark about the backlog also, so that if we align with the backlog and the patient marking, then patient setup will be more accurate. And this is the picture of a RTP marker. And in our center, we are putting RTP marker over the pelvic symphysis, and vertically it is 10 centimeter. Like one advantage is there, putting of this area. If we put in fiducial marker in for all cervical cancer in same area, then if patient removes the skin marking also or reference marking also, we can assume or we can guess, or we can set the patient by seeing our setup, because all cervical cancer we are putting in the same area, like 10 centimeter depth and over the pelvic symphysis. This way we can set the patient and we can take the image. And after that, we can identify our reference mark. And here is the several types of RTP markers. And here few are the MR compatible RTP markers, and few are the lead markers. And below two are the for scar marking. And RTP, one important thing is RTP marker if should be 2.5 millimeter, because we are taking during simulation we are taking 2.5 to 3 millimeter slice thickness in during CT. So if our marker is size, if our RTP marker size is less than 2.5 millimeter, then we might miss one marker. So our RTP marker should be in one line. If it is 2.5 millimeter, then we'll get all three markers in the same line. So here is the picture of RTP marker reference point, and as I told, the all three markers should be in the same line. Why it should be in the same line? In my next slide, I'll talk about this. And this is my reference center. After doing CT simulation, we are recognizing the machine. Okay, this is our reference center, and from here, and suppose this is our PTP and this is our the treatment center. So from here, from reference center to treatment center, how much distance is there? This shift will give, if I put all three reference point in same slice, then I will get the proper information like lateral, longe, and vertical shift. And now comes to the imaging procedure, how I should take the image during simulation. The patient position in supine with the hand over the chest, and positioning done with the proper devices. RTP marker placed properly. Scanning area, it should be from the diaphragm to mid-thigh, and slice thickness is 2.5 millimeter to 3 millimeter. And if use contrast media if required, and before using contrast media, we should check the creatinine level. If creatinine level is more, we should not use the contrast media. And use appropriate KB and MA for the better imaging, because better imaging can give us better result. And very much important thing is the documentation of the immobilization device, which are used in the CT simulation. And like one person did the simulation and another person is treating the in Linux machine. So he might don't know what the devices is used for this patient in the simulation. If documentation is there, anyone can come and anyone can see this is the documentation, and they can position the patient properly. Like in documentation, we should uh, include like how I position, like if patient is supine, prone, or prone, or we use backlog or prone pillow, or patient hands where we get over the head or over the chest, and bladder filling, how was it, like it empty or moderate bladder filling or full bladder filling instruction, or how much minute I spent after drinking water, and indexing where we kept the index, and where is our ankle position, where is our knee position, all we should um, entry in our all we should entry in for patient localization. And one more thing is very much important, which is patient identification. Like if it is a big, very much busy center, like one name, many patient comes in one name, like Mr. Hamid. Three patient comes Mr. Hamid, and they are different diagnosed. They diagnosed in different cases, but their name are same. If we call Mr. Hamid, then maybe instead of one patient, another patient comes. So before treating or before simulation, uh, we should check the proper patient came or not, or proper patient comes or not, and we should check the age, and we should ask his patient's father name, and what is the diagnosis. All we should check. Otherwise, we might treat the wrong patient also. And field placement of the cervical cancer. The superior border should be L4 to L5 junction, include the common iliac chain. Inferior border is the inferior level of the obturator foramen. In case of vaginal involvement, border may be at introos level, lateral posterior border S2 to 3 junction, and lateral anterior border halfway through the pelvic symphysis, pubic symphysis. And this is very much important, interpretation organ movement, which we cannot avoid. It can happen fraction to fraction. Though we are giving a 3D margin around the PTB, still this shift might come. So, and imaging, daily imaging can help to avoid this type of errors. So, if we take daily imaging, we might uh, we may improve the patient setup, and we can treat the proper area. Despite of availability of IMRT, approximately 50% radiotherapy centers in the Western world, IMRT is rarely used of cervical cancers because of the interfraction motion. So always we should take care about the interfraction motion. It is very much important in radiotherapy treatment. And then finally, radiotherapy treatment is comes. And the way we simulated the patient, the same way we should set in our uh, radiotherapy treatment room. And we should position properly according to our patient setup as documented. And after that, we should shift the patient according comes to the TPS, like reference to the treatment center. Then we'll take the image, finally we'll deliver the treatment. And before ending my simulation, I'll discuss about two slides about the planning. In my center, in our center, we did a small study, like 2D planning without any MLCs, and 2D planning with MLC and 3D CRT. And we saw in 2D planning, we are irradiating the more area which is unwanted, and 2D MLC we can reduce the little bit, but still we are irradiating the more area which we don't want. In 3D CRT, we can minimize normal tissue which we don't want to treat.
As we discussed in the previous slide about dose conformity, I would like to talk on conformity index comparison. The conformity index defined as the ratio of the reference isodose, which is 95% volume, to the target volume. For an example, when we are irradiating a volume of 100 cc, if reference isodose volume is 120 cc, which means we are irradiating 20% more. So similarly, we compared and studied 10 patients, the difference of conformity index between 2D, 2D MLC, and 3D CRT. We found in 2D, we are treating 660% more, and in 2D MLC, 360% more, and in 3D CRT, we are irradiating 150% more volume.
Thank you everyone for kind attention.